Good morning all. I am Dr. PJ Madam Rafi. Today we are going to discuss about local anesthetics. Okay. So first of all, local anesthetics are classified into two groups. One is amide group, next is ester group. Okay. So here you have to remember the drugs names. Okay. It's difficult, but it will be easy if you know the small this thing. Okay. So in amide group we'll have lignocaine, prilocaine, bupivacaine, dibucaine, ropivacaine. Okay. In ester group also we have cocaine, procaine, chlorprocaine, tetracaine, benzocaine. In both groups all drugs end with caine only. Okay. So easy to remember is in amide group we'll have two I's in the drug. That if you see lignocaine means here one eye, here one eye. Okay. Samely prilocaine double I, bupivacaine double I, dibucaine double I, ropivacaine double I. Okay. So here all drugs consisting of two I's in their name. If you see ester group, it will be consisting of only one I. Okay. So that's a major difference. So you can easily remember by the name itself. Okay. Amide group means it will also have I in the name. Okay. That means amide means single I in the name. So in the name itself have two I's. Okay. Amide have I, right? So the drugs consisting have two I's. Lignocaine, prilocaine, bupivacaine. So based on that we have to classify it. Okay. Next coming to the mechanism action of local anesthetics. So normally if depolarization happens, obviously the nerve conduction will be happens. Okay. If you see this is the normal because local anesthetic will acting on the nerve. Okay. That's why we have to know the mechanism action. So if you see this is the normal depolarization nerve. Okay. So first it will have two phases, resting phase, active phase. Okay. In resting phase obviously there will be no sodium conduction. In active phase obviously there will be sodium conduction. Okay. So this is how normal depolarization will happen. That means if the resting phase it will get depolarized, obviously gate will open, so it will influx sodium. This is the active phase. Here local anesthetics what they will do, they will make the sodium channel into the inactive stage. How that means, because these local anesthetics are basic drugs. Okay. When they enter into the cell, obviously inside the cell it will be acidic media. So obviously once this basic drug enter into the cell, it will become ionized. Okay. After ionized, it will bind the local anesthetic receptor. Thereby it will block the channel. Okay. So there how obviously it will not allow the sodium influx. Okay. That's why it will be make into the inactive stage. Okay. So this is how local anesthetics will act. Normally two phases, resting, active. Okay. Here one more stage, that is inactive. They are making this channel into inactive. That's why inactive stage. Okay. So how they will act? These are basic drugs. When they enter into this one unionized form to the ionized form, once they become ionized they will block the local anesthetic receptor. Once they block the local anesthetic receptor, obviously sodium influx will get blocked. Okay. That's it. Next thing. Next, what are the therapeutic uses? Okay. So therapeutic uses means we are mainly surface anesthesia. Okay. Next, infiltration anesthesia, nerve block, intravenous regional block, spinal anesthesia, epidural anesthesia. In all these things, we will use local anesthetics. We will discuss one by one. First is surface anesthesia. Okay. In surface anesthesia, obviously lignocaine is the most commonly used topical agent. Okay. Lignocaine is the most common. Next is in surface anesthesia, we have another drugs like emlacrine. Okay. This is the main thing. We have to remember the combination. If they ask the emlacrine means, what is the combination means? It will have 2.5% of prilocaine, 2.5% of lignocaine. It is a combination of drug. Okay. It is also used as a surface anesthesia. Next thing is, this is recently asked question. That means this is a surface anesthesia which will used as an antacid for gastritis. That is oxythiazide. Okay. The syrup will be mucin right? If we come in the name mucin. So in that it will consist of oxythiazide. Okay. This is the oxythiazide. It will act as a surface anesthesia for antacids. Okay. For gastritis patients, it will act as an antacid for gastritic patients. That means if you are taking this one, it will form a layer in the ulcer area. That's why it will cause that resistance. Okay. So obviously what is here is a MCQ, oxythiazide. That means it is a mucin antacid used as an antacid for gastritis patient. Okay. Next is infiltration anesthesia. Infiltration anesthesia means here we will give local anesthetic in subcutaneous region for minor surgeries, suturing in that areas. Okay, that means small surgeries or small suturing. Okay, if you want to do small time surgeries like that only, we will use infiltration. That means we will give subcutaneously. Obviously, after that, this local anesthesia will get infiltrated in the surrounding area. It will block the depolarization. Thereby, it will lock the sensation. So obviously we will do for the surgical manipulations. Okay. Next is nerve block conditions. Okay, when you are using some nerve block, so in those conditions we will use local anesthetics. Next is intravenous regional block. Okay, that is also known as BS block. This is an MCQ. So here most commonly drug of choice is prilocaine. Okay, bupivacaine we should not use because it is a cardiotoxic agent. So we will not use bupivacaine. Okay, this is also an MCQ. So we should avoid in sickle cell anemia. Why? Because in intravenous regional block, we'll increase the pressure. How they will give means we'll block cuff in the arm region, then we'll inject the drug, then we'll inflate the pressure. Because we will not allow the system, we will make systemic pressure, we will make the pressure above the systemic level. So obviously there will be no blood inflow. Okay. So obviously, if you are using in sickle cell anemia, there will be a chance of clotting will be there. So we will not use BS block in sickle cell anemia. This is an MCQ. Okay. Next is spinal anesthesia. Spinal anesthesia, we have to remember the spinal cord levels and where we will use. Okay, where we will inject also. So spinal cord normally ends L1 region in the adults. So where spinal anesthesia will be given? Obviously below that one. That means L2 to L3 bit. Okay. In between L2 and L3 spinal anesthesia will be given in adults. So where spinal cord ends L1 region. So L1 region will ends. So spinal anesthesia will be given in L2 to L3. Okay. In children, it will be up to L3. So obviously, after that only we have to give spinal anesthesia. That is L4 to L5. In between L4 and L5, we will give spinal anesthesia in children. Okay. Next, where we will inject spinal anesthesia? In subarachnoid space. Okay. This is an MCQ. So subarachnoid space means where it will be located. It will be in between the pia and arachnoid space. Okay. If you see in the spinal cord part, in between the pia and arachnoid space, there will be one space will be there, that is subarachnoid space. Okay, in that area only we will inject spinal anesthesia. Okay, so these are all very important MCQs you have to remember. Okay, next, indications of spinal anesthesia. Okay, so what are the indications of spinal anesthesia? First thing is we will use for orthopedic surgeries of lower limbs and pelvis. Second is surgeries of lower abdomen, that means hernia, hydrocele, appendix, pelvic and perineal surgeries. Next, gynec and obstetric surgeries also will use. Here the main complications of spinal anesthesia is hypotension. Okay, because of blood loss, obviously hypotension will be there because it will be acting on cardiac, so cardiac stability will be lost. So in that also will cause hypotension. Next main complication, this is an MCQ. Spinal anesthesia will induce post-dural puncture headache. Why? Because we are using spinal anesthesia, if we are using large bore needles, that means needle size will be increased. Obviously, it will cause more leaking of CSF, thereby decrease this ICT, intracranial tension. So, thereby obviously patient will feel post-dural puncture headache. This is the most common MCQ. Complication of spinal anesthesia is PDPH. Okay, post-dural puncture headache. Okay. So next is epidural anesthesia. Epidural anesthesia means here drug will be injected in epidural space. In spinal anesthesia, it will be injected in subarachnoid space. Okay. Epidural space in between dura mater and vertebrae, that ligament of flavum. Okay. Next is mainly used for controlling post-operative pain. Pain management only we will use epidural anesthesia. Okay. So that is painless labor conditions. Next, chronic pain due to cancer patients. Next, difficult to perform because this is a complicated, because we have to find the epidural space, so it is not easy for everyone. So we need experts to find out the epidural space, because it is a very narrow space in between the dura mater and this vertebrae. It's very narrow. We have to, by experience only we know which it is in epidural space, because if we go beyond that, obviously we will inject into the spinal anesthesia, because if we enter into the subarachnoid space, obviously it will belongs to spinal anesthesia. So it is very narrow, because if dura and vertebrae, in between that one, that is ligament of flavum. So in between that one only we have to be place the needle. then only you have to inject. Beyond that also causes problems, before that also causes problems. Okay, that's why we need experts. Here the less chance of main thing is PDPH will be less because we are not injecting into the spinal anesthesia, this subarachnoid space, because subarachnoid space only will have cerebrospinal fluid, because in epidural space we don't have cerebrospinal fluid. So there will be no chance of leaking of CSF. So there will be no chance of PDPH. Why in spinal anesthesia PDPH will be there? Obviously leaking of CSF fluid. Okay, when CSF fluid will be leaked morely, obviously it will cause PDPH, that is post-dural puncture headache. Okay, next. Thank you. Next is there will be some important points regarding local anesthesia we have to remember. First thing is myelinated fibers are more sensitive than non-myelinated fibers. When you are given anesthesia, myelinated fibers will get blocked first than non-myelinated fibers, because obviously if you have nerve conduction, myelin sheath will be there. It will have more sodium channels, so obviously it will acting on there first, right? So obviously it will block there first. Okay, what is the sequence of blockade? B fibers greater than C, A delta, A beta, A gamma, A alpha. First will be blocked by B fibers, followed by C, then followed by A delta, then followed by A beta, A gamma, A alpha. Okay. If you see in the fibers level, autonomic fibers are blocked first. Okay. They are greater than sensory, finally lastly motor. Okay, if reversal will be, obviously first motor will come, then sensory, then autonomic. That's why if you are doing any surgeries, we will see the bowel movements. Okay, that means if you are coming, the bowel movement belongs to the autonomic fiber. If bowel movements comes, obviously anesthesia will reversal. Okay, that's the main thing. Okay, first autonomic will, if you are, when you are giving drugs, obviously first autonomic will get blocked, then sensory, lastly final motor will block. It is when you are giving reversal, obviously after surgery over, we have to see the reversal of anesthesia. Then first motor will come, for we will see the movements, then sensory will ask that pain will be there, these things. Then obviously finally we will see the bowel movements, because if once bowel movements comes, local anesthesia will get over. Okay, next, here this is the most very important thing. All local anesthetics will cause vasodilation except cocaine, because cocaine will cause vasoconstriction. That's why we should not combine with adrenaline, because adrenaline also vasoconstrictor. It is also vasoconstrictor. There will be, it will cause complications. So we will not use cocaine with adrenaline. Okay. Next will bupivacaine induced ventricular tachycardia. What is the drug of choice? Means bretylium. Okay, this is an MCQ. That's why I am mentioning here. Next is local anesthetics which will cause methemoglobinemia. This is the main important. Methemoglobinemia will be caused by some other drugs also. That is inhalation drugs also there. Here, if you have to remember, we have to see whether they are asking local anesthetics or they are asking gases. That means inhalational agents. That will also cause methemoglobinemia. This local anesthetics will also cause methemoglobinemia. Okay, if local anesthetics means benzocaine, prilocaine, lignocaine. Okay. Next is local anesthesia used in malignant hyperthermia will be procaine. Okay, this is an MCQ. So what are the structures encountered during lumbar puncture? So when you are giving lumbar puncture, obviously if you are planning for spinal anesthesia, epidural anesthesia, we have to be pierce some structures. So this is the right MCQ. They can ask the order. Okay, we have to remember the order, the names and order. Okay, first will be skin, because obviously first will skin will come. Next, obviously cutaneous tissue, subcutaneous tissue. Next, supraspinal ligament will come. Next, infraspinal ligament will come. Then ligament of flavum. Okay. Next, dura mater. In between ligament of flavum and dura mater, we will have epidural space here. Okay. After that dura mater and arachnoid matter, there will be subarachnoid space. Okay. That means this is the main thing. Dura, arachnoid and pia mater will be there. Okay. So in between ligament of flavum and dura, epidural will be there. In between pia and arachnoid, subarachnoid space will be there. So you have to remember the names. Okay, in order also. Okay, first skin, subcutaneous tissue, supraspinous ligament, infraspinous ligament of flavum, dura mater, arachnoid mater, pia mater. Okay, that's all. Thank you.